lay off. Cool. All right, so that's groins. Now we'll get into a little bit about how I see rehab, um, and what kind of goes through my head as we go through this process, right? So, can you guys see my mouse? Awesome. So when I think about injury, I kind of think about this paradigm here. And if you've worked, especially in the team setting, I think you're probably pretty used to this, where athletes have a baseline level of preparedness, and all preparedness is a certain level of physical literacy that they're capable of. Injury occurs, and inherently that physical preparedness drops down, right? You're just not as capable of performing really much of anything at that standpoint. And then what happens is there's generally two models that I see kind of get carried out, and I'll talk to you about the issues with each. One being the traditional model, which is generally filled with rest, passive treatment, low intensity loading, and then a sharp spike in sport specific loading based off of timelines uh, driven from prehistoric literature and a lot of general populations. Right? And generally, the issues with this is it leaves the athletes very detrained and entering their sport back at a lower state of preparedness than before they got injured, right? And inherently, that doesn't make a whole lot of sense, right? Versus a tactical model, which emphasizes early optimal loading, a progressive criterion-based protocol where we're incrementally working the athlete back based on how they are responding as an individual, and then a collaborative return to sport protocol, with the goal being that we're actually putting them back at a heightened state of performance before they step back out onto the field, right? And so that's what I'll be talking to you about today. So anytime I talk about really anything training or rehab related, the first thing I almost always talk about is principles. I'm a really strong believer in having principles, being able to clearly define them, explain, what they are and what they mean to you and how they fit within your training in your rehab. I'm not going to go through all these today. That's kind of outside the scope, I think, of this presentation. But just to hit on them real quick, and you'll kind of pick up on some of the notes and what they mean as we go throughout this presentation. So for me, these are my big 12. Master movement, progressive overload, specificity, vertical integration, all injuries are brain injuries, assess, don't guess, reverse engineer, training lives on a continuum, periodization, plan B, keep the main thing, and then keep it simple. So we'll be going through a very linear model. So for me, I think in regards to rehab, it very much so lends itself to linear concepts, as opposed to maybe the team setting where you have to focus on so many different qualities at once, and you have to compete with the stressors of the sport that they're playing. So in my opinion, linear models don't really work with that. But in rehab, where you are working with an athlete generally one-on-one, you don't have to compete with outside stressors. We get phase potentiation, just meaning that the qualities that we lay early on in this process support and enhance the prerequisite qualities. I think it offers a lot of value, right? And I'll get into a little bit more of whether it's short-term or long-term rehab and what that looks like. But that doesn't mean, we're not training all qualities at once, right? Goes back to vertical integration of we're training everything always just to varying degrees of intensity, density, and volume. And then I think most importantly is just to understand that all of this just lives on a continuum of general to specific, simple to complex, isolated to integrated, and so on and so forth. Right. So how does that look for actual groin rehab? So this is kind of a condensed version of, everything that we're going to be talking about today. But really what I just want to talk to you about and kind of get you guys to visualize is this idea of this continuum of restoration, preparation, and realization, right? So with groins, as I talked about earlier, it could be as quick as a 7-day turnaround or a 6 months to a year turnaround, depending upon the severity of the injury, right? So I think it's important when we're creating these models that we're able to scale them out. And we'll kind of talk about that in the sense of, okay, short-term rehab, which is the case that I'll be walking you guys through today, right? That's just phases 1, 2, and 3 along the same continuum of days or weeks, a little bit more of a aggressive, conservative approach. Plan B approach, just meaning we're modifying the training to keep the athlete in the same training cycle as the rest of the team. We're removing any contradicting stressors and a more aggressive reacclimation back into the training environment versus long-term rehab, which would be phase 0 through 5, right? That's going to be months or years, generally requiring an invasive approach, fully modified training to that individual, and a very progressive reacclimation back into the team training, right? So now considerations specifically for groin rehab and specifically for strength. I think it's important that we consider all potential limiting factors for lumbopelvic strengthening and how they may impact each other. One that I found to be very common is ratios between specific muscles. In this case, the adductors to the lower abdomen. Oftentimes, if the adductors are too strong, they can pull the pelvis forward, which creates shearing forces across the inguinal wall, which can lead to herniations and a whole host of other stressors and injuries. All right. Then we can talk about intralimb deficits, meaning the deficits within the same limb. This has shown a very strong correlation in groin injuries, particularly if we're talking about testing adduction to abduction in their ratios. This can be done with, the Vold force frame on the top right, Kangatex, I know another popular one out there. Manual muscle testing, you can see at the bottom there. But basically, we're just trying to get the athlete to operate within a specific ratio of 80 to 120%. Anything outside of that being considered a red flag. And I'll talk about that a little bit more as we get into exit criterias. And then intralimb or inner limb deficits, just meaning the deficits between the left and the right limb. The groin is a very interwoven and complex structure, and neither side necessarily operates independently. Um, so making sure that we're within a symmetrical standpoint from 15% or less, for me is considered, or I should say, anything greater than 15% is considered a high risk factor. Other considerations, isometrics are going to play a very integral part in this process. They provide a very high return at a relatively low cost. The groin is also filled with copious amounts of connective tissue, which we know respond well to an isometric stimulus. And they become very popular, I think, especially in groin rehabs, large in part due to the testing aspect of it all. But that doesn't mean they don't have their limitations, right? I think isometrics will only improve strength within 5 to 10% of the range that they're trained in. So it's important that we make sure that we're training at all angles as opposed to just probably the most common or the easiest to train. And it's also important to understand that a lot of these injuries are also coming from eccentric overloading, right? Seen during the swing phase of skating or the wind up and follow through of kicking a ball. These eccentric deficits present following groin injuries, just furthering the importance of making sure that we're targeting all three contraction types kind of throughout this process. Core considerations. So the muscles that make up the pillar are going to greatly impact the pelvis and its function. Like I said before, the lower abs need to be able to posteriorly tilt the pelvis, and the obliques need to be able to support the pelvis in the frontal plane. So just make sure that you're training all sorts of, the course functions, bracing, rotation, flexion, and extension. Mobility considerations. So I love this quote from Dan Paff, a bad pulley will fray even the strongest rope, right? So I think for me and what I've found is that there's a very, very strong correlation between specifically hip internal and external rotation in their relation to groin injuries. So if you're looking at this video over here on the top right, you can see me assessing one of my athletes, taking him through hip flexed internal and external rotation. So for me, and the values that I've found that work for me, and what I've seen from a research standpoint is I like to see hip internal rotation of 35 degrees or greater, hip external rotation of 40 degrees or greater, and then a total arc, just mean adding those two up, of 75 degrees or greater, as well as a 10% left and right asymmetry from the left and right side. So anything outside of those numbers are going to be a red flag for me from an assessment standpoint. Um, Other mobility considerations or tests that we'll look at is the Table Thomas test. So very simple. I'm sure a lot of us are familiar with. Just laying on the table, hugging one knee up to your side, measuring the psoas. So is the hamstring separated from the table at all? Measuring the rec fem. Is there any excessive kickback from the quad when I press in on it? Some people will fail it if it's obtuse at all. I'll generally press it in and try to see if they have any sort of excessive strong kickback. And then measuring the TFL, is that front foot turned out, right? And then from there, we'll provide specific interventions based upon how they respond to each one of these tests. So specifically with groins, be very mindful of rushing back into stretching damaged tissue. The groin is a very, very sensitive area. Um, and while we want to restore range of motion early on in this process, going on and irritating it is probably only going to make it worse. So we want to focus on gradually restoring pain-free range of motion. Understand that there's going to be certain anatomical limitations that may prevent specifically hip flexed internal rotation. Just due to the structure of some athletes, they're going to really struggle being able to reach those positions. So, performing hip extended mobility that you see over there on the top left, or any sort of posterior hip shift drills that you can see on the top right. I've had a lot of success with those drills of maybe increasing our available range of motion there. So from a progression standpoint, we'll just work from soft tissue prep to passive to active mobility to end range strengthening. So structural considerations, right? So one thing I know to be true is structure dictates function. It's important that we account for all possible structural limitations, specifically with groins. Uh, One culprit being very common in groin injuries is femoral acetabular impingement, or FAI, if you're not familiar with it. All it is just a bony buildup due to repeated stress or genetic predisposition. This can present in one of two ways. CAM, where there's a lesion across the femoral head, presents about 70% of the time. And then pincer, which is a lesion across the rim of the acetabulum, that's going to present 30% of the time. And about 25% of cases are going to suffer from both, right? So this is very common in athletes with that have to change direction a lot. Your skating athletes, your soccer athletes, basketball athletes, and generally starts developing around ages 12 to 13, right? So signs for this can include restricted hip internal rotation, anterior pain with deep flexion, or any sort of radiating pain from the hip down into the groin. So if you're looking at this video over here on the right, that's just me taking my girlfriend through a hip scour test. This is an assessment note that I'll use with all my athletes coming in. And all I'm doing is I'm trying to drive the head of that or the head of the femur down into the acetabulum. And I'm just taking her through some rotation, and I'm just looking at her face to see, okay, is there any pain presenting with these movements? And it's been pretty crazy the amount of luck I've had identifying FAI on the front end before some of these injuries occur. Other structural considerations include the pubic symphysis, the SI joint, hip alignment. While a lot of structures are predetermined, I think it's important that we understand that we can influence some of these positions with manual intervention. Now, understand your scope of practice. I'm not a PT or an AT, massage therapist, but I do have a pretty solid understanding of some of these tools, and I think it's really important that you learn to get your hands on athletes and assess them. So just starting over on the far left, I think testing for hip alignment, specifically in groin injuries, I think is really valuable. So just placing your thumbs on the ASIS and trying to identify whether one side hiked up or depressed, I think gives you a good indication of where they're at. This video next to it, the inchworm drill, where you're just as slowly as you can laterally hip hiking through the left and right side, 5 to 10 times each. I've probably had more success with this and resetting the SI joint than anything I've ever done. It's one of those things that it's so simple, it works. Other things we can perform: abduction reset, adduction reset. I would just say be conscious of doing this too early on in the process because it may exacerbate pain. But a lot of the times, many of these injuries, or I should say symptoms, are stemming from an offset pubic symphysis that some of these resets have shown to be able to realign, right? Motor control considerations. So the inability to control the pelvis is often a culprit behind increased stress across the lumbopelvic region. For me, rehab is an opportunity to slow things down and reteach some of these fine motor skills that you may not otherwise have the time to do in the team setting. So just taking the time to, I think, reteach some of these basic patterns, working from the pelvis out, like some of this block zero work. When you have an athlete one-on-one, I think it can pay a lot of dividends down the road, and something I don't think enough practitioners do with their new developmental athletes. Something I'm a really big fan of. All right, now movement strategy considerations. So in my experience, athletes that present with a consistent injury pattern that quote unquote normal rehab fails to address involves one of three things. It's either poor management or practice, they have structural limitations, or three, and what I found to usually actually be the most common is just a poor movement strategy, right? So movement is to me is the one quality at which all other qualities are expressed, right? I've worked with a lot of really elite athletes, and I can say for certain that generally the best athletes are the best movers, right? We can't say that for all other physical abilities. But for me, I just think it's so important that we have a technical model to evaluate these movement strategies, so we can start to peel back some of the layers of how the athlete is moving and what may be the missing link kind of in this process. So one thing I want to point towards is some of James Wild's work from 2022. It was a study on linking acceleration strategies and injury sites. So on the y-axis here, we have high stride length and low stride length. On the x-axis, we have short ground contact time and long ground contact time, right? And so from each one of these quadrants, they were able to identify certain archetypes, right? Those being bounders, striders, bouncers, and spinners. Okay, so generally, the deeper you were into one of these uh, quadrants, the more that you expressed some of these more common injury patterns, right? So the one I want to point out to you specifically are these spinners here, right? So these are athletes that spend a lot of time on the ground and have a relatively low stride length, meaning that they're high frequency athletes, right? So the metaphor in my head is if you've ever tried to get out of like a mud pile with a truck, right? The wheels just kind of spin in place, right? They're trying to win with frequency, but they're spending a lot of time on the ground. So what that tells me is there's a lot of undue stress happening at the hip, right? And we can see that reflect in their injury history because 43% of the injuries that they sustained are at the hip flexors and at the adductors. And while I think there's a lot more research that needs to be done on this, I can say from my own experience that a lot of the athletes that I've had that have presented with groin or hip issues are this archetype, or at least one of these archetypes that try to win with a little bit more frequency. So I think just in general, all of these archetypes are effective, right? One's not necessarily better than the other, but for me, I think they could all be more efficient, which is why, like, when I take on an athlete and specifically in a return to play case, I'm trying to nudge them back towards the middle to a little bit more of a neutral pattern, right? And so how I do that is I came up with these four high intensity actions, right? And I shouldn't say I came up with it. I stole it from Alan Murdoch, but I've kind of manipulated it for my own use. And so for me, intensity is the true gauge for how we should see return to play in sport. So for me, it just only makes sense that we use the most high intensity actions to reverse engineer those concepts, right? So I'm not going to go through these super in depth, but for me, those four actions are acceleration, max velocity or upright running, lateral gait or change of direction, and then deceleration. Okay, and then you can see that each one of these movement qualities has a posture, right? So just certain positions that the athlete needs to be able to hit, a pattern, so how they transition from each one of those positions, and then power or physical qualities that underpin these movement skills, right? So I just think it's going back to my point earlier. I think it's so important that we have some sort of technical model that makes sense to you, uh, that allows us to kind of reverse engineer good movement and try to guide athlete back and try to identify maybe what's causing these issues. All right, so that's about kind of me and my methods, and now a little bit more about the rehab process. So, all right, we have a groin injury. Where were we? Where are we now? Where do we need to go? Let's create a roadmap. All right, so let's focus on what you can do, not necessarily what you can't do. We're going to develop a criterion-based system as opposed to timeline, filled with objectives and methods. That just means themes that we're going to apply throughout each phase. Isolated rehab, which just involves passive treatment, mobility, and strengthening. The return to run process, which is going to include your linear and multi-directional progressions, as well as your conditioning. And then specific exit criteria made up of subjective and objective tests that show the athlete is prepared to progress forward, right? So just a few things to remember. Long-term rehab is an opportunity to refine and develop, right? It's very rare that you will ever get the opportunity to work with an athlete one-on-one without having to compete with the stressors of their sport. So take advantage of it. There's things that we can do now, especially early in this process, to set them up for the rest of their career. And then lastly, and most important to me, the same rules of training apply to a healthy athlete as they do an injured athlete. Just remember that the base is lower and the price of error is higher, right? So you can make minor mistakes with a healthy athlete. Trust me, I've done it a bunch. You can't afford to make mistakes with an injured athlete. So we need to narrow in our scope of practice and really dial it in to what that athlete needs at that time. So injuries specifically that I'm going to be talking to you about today, just because they are the most common, is just an acute adductor strain. So what is it? It's damage or irritated adductor longus or gracilis at the musculotendinous junction or the bone tendon junction, generally in the more proximal area. It just presents with pain running through the thigh up into the groin, generally looking at 4 to 8 weeks in acute scenarios, and in chronic scenarios as much as 6 months. So phase one, objectives and methods. So the primary emphasis right now is to just restore range of motion, motor control, and movement competency, identification, whether that's through MRI, CAT scan, ultrasound, palpation, or evaluation. This is a time, especially if you're in the team setting, for planning and communication. Make sure all the stakeholders are on board, sports medicine, the sport coaches, the athlete, sport performance, nutrition, so on and so forth. Understand that groin injuries are often from doing too much. So rushing back to do more necessarily isn't going to be the answer. And I'll kind of contradict myself with that here in a little bit. But contraindications for this time, any movement that's going to put the athlete into an excessive anterior pelvic tilt, transverse or frontal plane movement, split stance positions, deep hip flexion or excessive abdominal bracing. So isolated rehab in this phase, lots of passive treatments, EMS, BFR, lymphatic massage. I'm a big fan of compression or just sleeves. I think provide a lot of value. If you're looking over this picture here on the right, I think in extreme cases, one thing I've had a lot of luck with is actually doing BFR and EMS simultaneously and just passively, right? Because if we think about it, the EMS causes muscular contractions through no effort, and the BFR provides a hormonal response. So we can just hook the athlete up to an EMS and a BFR simultaneously at that specific injury site and get a lot of, I think, positive effects from it. So something that, I like and I've had a lot of success with. Modified conditioning. So generally just upper body conditioning during this phase. We'll get 2 to 3 exposures a week of either steady state or interval-based work. We will start to do some low intensity isometrics very early on in this process. I'm a very strong believer in starting those uh, really as soon as I'm allowed to. I've done it as early as hours following injury. Um, and the reason that we do that, I mean, it is a minimal effective dose, but we get this mechanotransduction effect, which basically is a mechanical trigger for cell-to-cell communication and effector cell response, just meaning that it helps mitigate inhibitions, guarding, and the tissue shortening that we generally see following a soft tissue injury. And then return to run during this phase is very simple. All we're trying to do is just restore walking gait, right? So phase one is very simple, very quick. Exit criteria, official diagnosis from the sports medicine team. Make sure that you get one. That's a mistake that I've made in the past of letting them slide by just calling something groin pain. Make them look deeper and make them identify what's going on, because what's good for, let's say, an adductor strain could be completely detrimental to some sort of stress fracture. So hold them accountable to that, make them do their jobs. A subjective decrease in overall pain, tolerance to low intensity, extensive isometrics, and just a normalized walking gait. Phase two. All right. So now the primary emphasis is to restore strength, tissue tolerance, and begin our return to run process. The severity of the injury is going to dictate much of what the athlete can tolerate early on. So be prepared to start with the lowest common denominator. All of our rehab is going to be done on a scale of less than or equal to 3 out of 10. What I will say with this is I probably lean towards the lower side of these numbers, just because what I found is that athletes they have a considerably higher pain threshold than general population, right? We know that from research standpoint. And a lot of these pain scale numbers are actually driven from general populations. And I've had a lot of athletes that are just when they say they're at a 3 out of 10, they're probably closer to a 6 out of 10. Um, so I just generally bias those lower numbers, right? In terms of a structure, we'll go 2 days on, 1 day off, kind of a high-low setup of Mondays and Thursdays will be our drills, our sprints, our change of direction, and our isometric work, with Tuesdays and Fridays being our tempo variations and our dynamic contractions, with Wednesdays, Saturdays, and Sundays off, depending upon kind of where they're at in the process. So isolated rehab, we're performing active mobility. The strength training progression will start with extensive isometrics to intensive isometrics to dynamic strength. When I say that, I just mean um, all three contraction types. If the strain is more proximal, which oftentimes they are, we'll consider using BFR to flood the less vascular tissue, right? So that's one thing to understand, that the higher the strain is, the less blood flow that they're going to get to that area, versus if the more distal it is, the more blood flow and saturated oxygen they're going to get to that area. Um, so just all that to say is that BFRs, I think, are really valuable too in this tool in this scenario. We'll use various hip flexion and adduction angles to target or avoid specific tissue sites. You'll identify pretty early on that they're going to be able to tolerate certain things, and then other things are just going to set them off. Okay, and that doesn't mean that we don't want to necessarily restore those movements that bother them. Um, but right now, we just want to find what we can load and progress it. All right. So extensive isometrics, huge fan of this, especially early on in the process. Understand that the lower the intensity, the more frequent the exposure can be. Oftentimes, these groin injuries stem from excessive amounts of jerking that we see during dynamic sport. So we want to start very light and then gradually build up the intensity of the contraction. I usually tell them to start out at a 2 and then go to a 4 and then a 6, and then um, about halfway through the contraction or 10 seconds in, they should be at a full contraction. We'll pair this oftentimes with EMS. We'll perform 4 to 8 sets, generally 30 seconds, and 2 to 3 exposures a day, separated by 6 hours. If you look at some of Keith Barr's research, what they found is that we can get collagen buildup in as short a time as 6 hours with some of these extensive protocols, which is why we're able to do it multiple times a day. So I've had athletes, perform at 8 a.m., 2 p.m., and then again at 8 p.m. before they go to bed at night. And we do that particularly longer than 30 seconds because we get this tendon creep response, right? So if you do isometric shorter than 30 seconds, what you actually get is oftentimes just a lengthening of the tissue. But after that 30 seconds, we actually get to see some lengthening at the tendon, and we start to see that specific area fill with some more connective tissue, right? So I just think there's a lot of value in that. Once they've shown that they can tolerate those, we'll progress to intensive isometrics. All that is just more intensive variations, generally Copenhagen progressions. Short lever to long lever to quasi isometric, like you can see at the top. 3 to 5 sets, 10 to 20 seconds daily. So these are probably too little intense to be performing multiple times a day, but still can be performed, in my opinion, every 24 hours. Once they've shown a tolerance for that, we can get into our dynamic contractions, prioritizing the eccentric portion of the movement. These will require 24 hours to 48 hours off in between each exposure just because of the damage to the tissue site. But I just think it's so important to start to restore some of those eccentric deficits. So we'll progress from open chain to closed chain, 3 to 4 sets, 6 to 10 reps each side, again, performing every other day. All right, so now getting into the return to run during phase 2. Right now, we're not worried about the demands of the sport. We're focusing on restoring movement competency. So a common mistake that I made very early on in my, I guess, rehab process was, especially in soccer, it's very common to want to rush to some of the more GPS-driven metrics where we're starting at X amount of a load or decelerations or high-speed distance, and fill those with physical buckets. What I've come to understand is that the context of that data is just so different than general physical training, that it doesn't really make sense, even at the lower thresholds. So I won't really bother messing with those until I get to actually returning to the sport. or closer to that end stage. So right now, like I said, we're just trying to restore general movement competency, teaching linear progressions and multi-directional progressions through low intensity drills. Every single rep that they do out in the field with me, I'll track pain from 0 to 10, and then their perceived intensity from 0 to 100%. Right. So after every single sprint, every single change of direction, they'll give me a 0 to 10, and then how intense they thought they were able to perform that drill. Right. So still staying under that 3 out of 10 on the pain threshold, never jumping more than 2 points without intervention. If they jump, let's say they started the session out with a 1 out of 10, and now they're at a 3, that tells me I either need to regress the drill or the tissue has reached its capacity for that day and we need to cut the session, right? So going back to reverse engineering some of those high intensity actions, what I did was I created just 5 very simple progressions that I can perform out on the field with guys. 4 lateral gait, 4 deceleration, 4 acceleration, and max velocity. And what I like about it is by starting at the lowest common denominator, of even if you're just looking at the top left there, just an unresisted step replace, we can start to restore some of these movement patterns, start to reteach uh, maybe some of their issues with these movement patterns. We also get some very specific physical development. And then lastly, it's just a great way to, I think, to assess where the athlete is at and kind of what they can tolerate, as well as maybe kind of prod out what's exacerbating pain, right? So I'll quickly show these. It's nothing crazy. It's just very 5 simple drills that I know that the athlete's going to be able to perform, whether it's basically day 1 of return to run or they're getting very close to actually returning to their sport, right? And the one thing I'll say with these is don't ever give an athlete something that's far too remedial for them, right? Like I love these long-term linear progressions as much as anybody, but the goal at the end of the day is to get them back out into the field. So if they're ready for more, don't be afraid to progress them on, right? So more into the phase 2 running. All right, our linear progression, prep drills into resisted sprints, unresisted sprints into curvilinear sprints. Multi-directional, we'll start with our prep drills into our 8 vector cuts, our change of direction drills, and then if we find it necessary, we'll get into some agility. For me, specifically with groins, I want to make sure that I expose them to specific multi-directional movements before I put them out on the field. Those being 180-degree cut, 135-degree cut, 90-degree cut, and 45-degree cut. Shuffles, crossovers, back pedal, jump cut, drop step, and curve run, as well as various amounts of decelerations. And just to understand that the closer that we get to returning to sport, the more that these drills should start to look like their sport. All right, so here's 2 examples of 2 days, what would be like a Monday and a Tuesday during this phase. And I'm not going to go too in depth into them, but Monday would be day 1. So a lot of these sessions follow the same kind of design as I would training, right? We have a general warm up, we have our tissue prep, we have our mobility. Then we'll get out into the field. We'll do our movement prep drills, maybe some resisted sprints, some unresisted sprints, some closed change direction. One thing I want to point to you out is that anytime, specifically in rehab cases, everything I program is done in ranges, just because I never know how that athlete is going to respond on any given day. And the positive about working in a one-on-one scenario is that I have the freedom to change things based on how they're responding as an individual, right? And then from there into the rehab process on a Monday, we would be doing some more isometric and quasi-isometric movements. Specifically with an adductor strain, I'd probably hit the adductor in 2 different ways, one more intensive, one more extensive. I'll hit the hamstring, I'll hit the adductors, and then I'll probably hit 2 core variations, right? And then Tuesday, similar setup. We'll do our warm up, we'll hit our movement prep drills, we'll get into our tempo variations. This could be, linear extensive tempos, curvilinear tempos, some sort of movement scale into a tempo. And then now we're just focusing on more dynamic contractions. Still hitting the adductor twice, still hitting the hamstring, still hitting the abductors, and then 2 core movements as well. And one thing I want to point out with this is like I probably put more in here than, to be honest, I actually would in a rehab session. just because when I design these sessions, my main thought process is what adaptation am I trying to drive? So this is kind of the extent of what I would do in a later stage rehab process. But if I'm being honest with you, like, especially if I think that there's imbalances, I may only do 1 to 3 things and just try to chase the intensity as much as I can, right? Because at the end of the day, it's not necessarily about hitting as many different things as I can and checking boxes. It's about driving adaptation, right? So exit criteria for phase two, subjectively, a tolerance to dynamic strength training, a tolerance to maximal linear sprinting and multi-directional movement, greater than or equal to 85% of general performance markers. Okay, so this one's very context driven in the sense that, right, if you're working with an athlete in a short-term scenario and you're trying to get them back to their sport, you're not going to run them through every single test that they do, right? It may just be a counter movement jump. Maybe it's a max velocity sprint. I don't know what it is. If it was a longer term scenario, yeah, I may retest them on just about everything. But for me, it's just trying to identify, like, okay, from a general performance perspective, are they within 15% of their standard performance, right? So now getting into more specific to the groin, these would be the same test, just a hip flex, DR and IR. Have they restored 100% of their individual baseline range of motion from an ER and IR standpoint? Is there less than a 15% asymmetry between the left and the right side from hip ER and IR? Are they within 80 to 120% of their adduction to abduction ratio? And then from a left and right side, adduction to abduction ratio, is it less than 15%, right? So phase three, primary emphasis now is to gradually reacclimate back into the training environment. You should be able to use your position coaches to develop skill work while giving them specific constraints to work with. This is oftentimes not the case. Oftentimes we have to be the practitioner that fills that role. So it's important that we understand the demands of the sport and reverse engineer what it is that we're preparing the athlete for, right? Sometimes we have to be the coach. Um, have a progressive loading scheme that can be scaled to shorter or longer. And I'll talk about that, I think, in my next 2 slides. And then lastly, just have a documented plan that all the stakeholders understand. I can't tell you how many times I've worked with an athlete where, we hand them back to the coaches with all these contraindications of what they're capable of and this really well detailed plan. And then, they just get lost in the shuffle. So make sure that you have a plan on paper that everybody understands. Isolated rehab during this phase, it's generally just going to be supplemental at this standpoint. We'll perform some end range strengthening, so like some FRC protocols, some high jerk rate strengthening, and then return to run. Primarily, this bucket will get filled with practice and training, but if we feel like it's necessary, we can perform some repeat sprints, some long or short intervals, some game simulations, or some position specific drills with the athlete. So just to touch on this real quick, because this is probably the one strength quality that I would still work with them on. I'm a big fan of these oscillatory isometric or these oscillatory movements in later stage rehabs. Oftentimes, our limitations in our ability to produce force is our inability to contract and relax at rapid rates, and it can be very hard to replicate high speed adduction and abduction without invoking pain. So I think these oscillatory methods serve a great tool to kind of bridge the gap between movement and sporting actions. And then more importantly, like, if you're working in the team setting, I've oftentimes been in scenarios where maybe the athlete hasn't been cleared for a return to run, even though I'm well aware that they can. So I'll generally lean a little bit more on some of these modalities, right? So just performing 2 to 3 sets, 6 to 15 seconds, 2 to 3 exposures a week. Now getting into specifically the return to play process. So for me, and I know this may kind of seem like a lot, but I used 4 weeks just because it's the most digestible, but we could scale this out to 12 days in 3-day increments, or we could scale this out to an entire 4 to 5 months. Okay. Again, it goes back to the idea of making sure that your return to sport is scalable, right? So what we're looking at here, if week one, right, the athlete would perform 55% of the total training load, right? Ideally, with that 55% being made up of 50% intensity, right? And intensity to me in this is specifically to soccer, but high speed distance over 75%, accelerations or decelerations over 3 meters per second, and any drill involving player load per minute greater than 4, right? And then 50% volume, and that just means our total distance, player load, or total time. I use 15% increments just because kind of the golden rule of thumb. You never want to make a jump more than 15%, and 55% generally seems like a good place to start. So the next week would be 70% with a little bit more focus on volume and a little bit less on intensity to make sure they can handle the capacity. The following week, 85% of the team training load with a higher intensity focus and a little bit less of a volume focus. And then week 4 being a full return to team training, equally distributed between intensity and volume, right? So finishing up here, exit criteria, most importantly, a clearance from all medical staff, tolerance to practice and training demands. Going back to our performance metrics, I would just like to see them within 10% of their previous benchmarks and whatever performance markers you're testing at that time. Ideally, in long-term scenarios, we would like to see them higher than these ranges or higher than their previous benchmarks, right? We want to increase their level of physical preparedness, but especially if you're working with an athlete returning in season, it just doesn't make a whole lot of sense to try to push those outputs there, in my opinion. Range of motion standpoint, now we're getting back to a little bit more of not just what the individual their baseline, but trying to reach those benchmarks of 35 degrees, 40 degrees, and a total arc of 75. Now, this one should probably be in quotations because certain athletes just structurally aren't going to be able to ever reach these benchmarks, right? It's just not the way that they're made. So take it with a grain of salt. We want to make sure it's improved and that they do have access to pain-free range of motion, but understand that that's not going to be ideal for everybody. All right. And then one that I am pretty hard and set on is I would love to see a less than 10% range of motion asymmetry between the left and the right side. All right. Going back to our adduction to abduction ratios, still within 80 to 120%, less than a 10% asymmetry between left and right side, and then a 6% increase in adduction peak force. Right. Why do I pick 6%? That's just what the literature has shown to be a significant change in professional soccer players, right? And then lastly, just the maintenance of all of our previous benchmarks up to this point. Those are my references. And then I'll leave this up so we can bounce back and forth if anybody has any questions, but feel free to reach out at my phone number, email, pretty active on social media, either one of those handles on Instagram or Twitter, website. And yeah, any questions?
That's fantastic, Connor. Thank you so much. That is like a ton of experience and expertise all at the same time. So thank you a ton. We have let's have one or two questions. If someone wants to come off mute, they're welcome to jump in. I know Darius had asked a question. Will the presentation be shared with us? Is that something that you share, Connor?
Yeah, absolutely. So I think, to my understanding, you guys send the recordings out anyways.
We usually
Um,
send the recordings out, yeah.
yeah, and then if you do want access to this presentation, please just email me. I can't send you the videos just because that's a nightmare. But what I will do is I'll download the PDFs and I'll send those out to anybody that was here today, or so on and so forth.
It's awesome. If anyone wants to come off mute, they're welcome to. Um, Connor, I did want to ask one question. If you could add only one exercise to a S&C coach's programming to help their athletes avoid groin injuries, what would that be?
Mm, one exercise. That's a tough one.
You can
Hmm.
go two or three if you need to.
Yeah, so what I would just say is this is I would just add any sort of progressive loading to the groin area that accounts for the sporting demands, right? So what I mean by that is like I think specifically with like athletes that generally deal with these kinds of injuries, Um, they're high volume sports such as soccer, hockey, lacrosse, field hockey, so on and so forth. Um, and so it's important that you maintain those things. And I think isometrics, specifically, I think Copenhagen planks are great. Lying med ball groin squeezes are great for athletes to maintain some of those strength qualities at the groin complex. But what I will say is that you do need to be able to modify based on how much loading is happening, meaning some athletes may need, you know, uh, 3 to 4 sets a week, while other athletes that are playing entire matches jammed in incredibly dense uh, periods of loading, like playing 3 to 4 games in a week, adding more would only be adding to the fire. So I know that's kind of a cop out, but I would say really any like the big two, I would say Copenhagen planks and then just a lying 45-degree hip flex, uh, med ball groin squeeze ISO.
Got it. Okay. Michael asked, and we actually have to adjourn here in just a couple of minutes, but he says, have you worked with a thrower experiencing growing pain? How did your return criteria change with an athlete loading one side much more frequently?
Yeah, so I throwing athlete, not a thrower in the sense of track and field, if that's what he's asking. I've never done that. I have worked with baseball players that have suffered from this issue. Um, and it's really not too different. I would just say the only difference being is a lot more uh thought process going into the return to throw. And really slow cooking that process and understanding the demands that they're under, right? So if we look at a lot of these asymmetrical sports from a strength standpoint, generally they're actually going to be pretty close on the dominant side. What I find generally to be an issue is the range of motion. Now, some may say that's a positive adaptation. I don't know that there's a correct answer to that, but to answer the question, I would just say not really. Just most importantly is just that gradual return to throwing is the most important piece there.
Got it. Well, Connor, again, thank you a ton for doing this. This has been like exceptional. We really appreciate the download. So thank you for taking time.
No, thank you guys for the platform. And like I said, if there's anyone out there want access to these slides, please just shoot me an email, and I'll get them over to you as soon as I can.
Okay, cool. Thank you a ton.